after hearing the first three speakers, if you're not pissed off about the American healthcare system, then you're either dead or you're just not paying attention. I sat back there and just got infuriated. It's hard to believe. Now, I have to say a couple things before I start. First, I'm not a health literacy expert. In fact, if you would read any of my emails or my notes, you would think that I, in fact, have no literacy ability at all, at least spelling in terms of literacy. Second, if there's anything about this talk that you like, it is because of James Tulsky, who will be going to Harvard in the fall, and Tony Bach, who's at the University of Washington in Seattle, because much of it comes from work that we've been doing for over 15 years now, through Vital Talk, which is a nonprofit that focuses on trying to teach communication skills as a way to change the culture of medicine. Third, and I found this very interesting in listening to Diane's talk, I listened to her talk and kept thinking, palliative care, what the hell's that? Isn't she just talking about good medicine? I mean, why do we call it palliative care? Why don't we call it what healthcare should be? That'd be a lot easier for patients to understand rather than giving it this word that everybody's like, well, what's that? And then you have to sort of explain what it is. And they're confused because are they talking about palliative care for like as a subspecialist, what Diane and I are? Or are they talking about like what every doctor, nurse, and social worker should develop a healthcare system to do? And I think to a certain extent, we diminish what the healthcare system should do by calling it palliative care. We ought to just call it good healthcare. And if we did that, then it would be a conference on health literacy and good healthcare for really sick people. And so I wonder whether that's one of the conclusions I took out of this. Because, and I was talking to some people during the break, this really seems like a culture change project. This isn't really about sort of single system problems. This is a culture change problem, and it reminded me that almost everything intelligent has already been said before, and we just say it over and over again because no one seems to be listening. There's a book by Elliot Mishler that I read when I was a master's student in medical ethics on the world of medicine, and basically talked about there was a world of medicine and there was a world of patients and how the two never talked to each other. And I listened to the second speaker and I just said to myself, oh my God, it's just this, it's 50 years old and we're doing the same things and we haven't learned any lessons. And in fact, what still isn't happening. What still isn't happening is that you have a really sick woman with a hematologic malignancy and you have her doctor typing at a computer and not paying any attention to her. The story that we tell in medicine is that the family doesn't get it. It's all the family's problem. It's sort of like patients, they have low health literacy, it's all their problem. That's what the house staff say. The people here who do work in health literacy have moved way beyond that, but that's still the story. Their expectations are off the wall. Why don't they see it? If you haven't read this book, A Doctor, it's a really sad book. And here's why it's sad. She's no longer a trusting and deferential patient. Like me, she no longer saw her doctors as healers. They're skilled technicians with their own agendas. That if patients have gotten a little smarter, they believe in science, but they don't have the same view about their doctors anymore because they don't seem like we get it. Particularly when you have serious illness, we can't fix it. So the science stuff that they've been sold isn't true. And we don't seem to care about what their lives are like. And in fact, I work in a hospital and the house staff say to me, the patient's going home. And I say, oh, okay, what's going to happen at home? They don't have any idea. The patient's going to the nursing home. What do you think will happen in the next 6 months? And they say, well, they'll probably die. Does anyone talk to the patient and the family about how to prepare for what happens so they don't get a call at 3 o'clock in the morning? No, it's out of sight, out of mind. In fact, what we've done to the culture of medicine is we split it into all these little tribes where no one really knows the patient. Of the things that made my head explode, the New England Journal, which is finally getting it, ran this debate about who should talk to this dying woman with cancer about advanced directives. And Diane wrote, it's the palliative care subspecialist who should do it.
Because they made me do it.
Hey, Tony Bach wrote, it's the oncologist who should do it. Susan Toole said, well, it's the primary care doctor. And my response was, really? Given that in studies that have been done, only 30% of the time anybody does it, we're going to fight over who should do it? So the question is, can you teach a better way? Can you change the culture so that clinicians can talk to patients and really talk? And the answer is like, I don't have to tell you the answer. If any of you are in medicine, you know Cochrane reviews. Those are like the highest level of scientific data. For 99% of the things in palliative care, their answer is there isn't enough data to reach a conclusion. About teaching communication skills, they said you can teach doctors how to improve their communication skills. And what Vital Talk has done, and what I've basically done with Tony and James for the last 15 years, is to teach doctors at the times that really matter to pay attention. And to, in fact, talk like human beings. Because the biggest problem that doctors have is that we've trained them very successfully to talk to patients as if they were talking to their attending. And the patients we like are the ones who've learned to talk to us like their house staff. And all of you who are doctors know them. You walk in, you say to the patient, so you can tell me what's going on? And the patient said, well, I had 2B, I had neck cancer, and I had chemotherapy, and then 5 years later I had a remission, and they in fact present just like they were a good medical student. Or they say I had right coronary artery disease, and they did a, they ballooned it, and then 2 years, and it's fabulous. So how do you do it? We started off 15 years ago with an NCI grant, a 4-day course for 115 oncology fellows, where we trained actors to be patients. We varied their age, their gender, their social economic status, and most importantly, we didn't teach them any medicine. And they would say to us, well, what does it mean that I got all this stuff? And we said, oh, don't worry about it. If the doctor can't explain it to you, you're confused. Because that's how patients normally are. And we recorded the doctors pre and post. Most interestingly, we had these people listen to them, and they had to tell us, is it a pre-audio tape or a post-audio tape? 95% of the time, they could tell us whether it was a pre or a post. And what they kept saying to us is, oh my God, what did you do to them? Now, this is data from the archives that basically shows what they were like pre and then what they were like post. And basically what it showed is that we taught them 8 communication skills. The most important of those communication skills gets to what Diane was talking about. We taught them to deal with emotion. Because doctors don't like emotions. I mean, think about it. How do you get to be a doctor? You go to the library. Well, now you don't go to the library. You just stay at home and you're on your computer. But when I went to medical school, you go to the library, you spend hours in the library, you memorize a lot of facts, you take these tests where you have to regurgitate it back, you get into medical school. You go to medical school, they tell you how stupid you are, you learn facts. You basically are a little, what Tony Bach calls a factoid machine. Emotions make you really uncomfortable. And so when you get uncomfortable, you fall back to what you normally do, which is you say, well, I guess we could try this because it's another thing. The patient then calms down, right? Because, oh my goodness, there's something else you can do. The doctor's like, oh my God, thank God they calmed down. The reason that doctor didn't want to go see the patient who was in hospice is that it made them too sad. I'm going to skip this. It's basically a quote that said, I tried something and it worked. This is a person who one person went home and tried out her new skills. The very first patient said to her, no doctor has ever talked to me like this. So Leslie Fallowfield has done the same thing with oncology attendings, showed the same thing. And not only that, 6 months after the study, she found that they were even better because they liked it. It changed their practice. They were able to address barriers when you teach this way in a way that they were able to see from other people how it worked. They were able to watch people do it well because many of them had never seen it done well. They were to practice with simulated patients and get individualized feedback. There's no reason to think that people know how to do this. In fact, most of us don't know how to do it. That's why in Amazon there are 10,000 books on how to talk to your spouse. Doctors don't know how to talk to seriously ill patients. There's no reason to expect that they will. You have to teach them. The problem with these approaches, I'm going to skip this. The problem with these approaches is that they're really time intensive. They're one person, and you need to have them go to a course for 3 or 4 days. So what we've been doing most recently with James Tolsky is we did a randomized controlled trial to use the same intervention, but we put it on the web, and the goal was to improve oncologists' responses to patient expressions of negative emotions. And we gave them a CD-ROM where they could watch themselves when they did it well, and they could watch other oncologists do it well, and we motivated them to spend time to watch it and to try it. All 24 oncologists received the CD. They spent basically an hour doing it. They all said it changed their practice, but like really, what are they gonna say? This is what's interesting. If you look at their ability to be different, they basically doubled the percentage of times that they responded to negative emotions. Not only that, when we talked to patients, patients said, these doctors were more empathic. So you can teach them to do it. Now the question is a scale issue. Diane has shown that specialty palliative care improves patients' experiences. Now the problem is a scale issue. How do you teach all doctors how to give good medicine? We've shown that these specialists can do it. And we're currently in the middle of a study with the ABIM to, in fact, give MOC, that's continuing education credit, to oncologists to do the SCOPE trial and to see whether it has the same effect. Because here's the real key. This is a question of political will and culture change. Doctors are pretty comfortable doing what doctors have done. Tom Smith said to you, oncologists, they don't have it in their DNA. My view is they either need it in their DNA or they need to get out of medicine. And we, as a culture, need to say, medicine needs to change. We need to learn to talk to people in ways that they understand. It's the doctor's job. It's the nurse's job. Or they shouldn't get reimbursed for what they're doing. They shouldn't have their job. We can get someone who can do it better. Thank you.